我叫荒井秀典，我来自长寿医疗中心。That's all. Thank you. I try my best. Okay. Thank you again for the invitation. It's my great honor to be here, and I'd like to share our data with you in terms of the healthy and active aging. And today's topic is healthy aging, and everybody want to be active and healthy, and doesn't want to be aged older person with disability. What is the trick? Of course, genetics plays an important role, but at the same time, education, health literacy, healthy lifestyle, and also social factor playing an important role. So I'm a geriatrician. So the role of healthcare professional is of course, it's big, but the government and industry, the role of industry and government is also big. So for the healthy aging, we should collaborate each other, healthcare industry, healthcare professional, industry, and government. The collaboration is very important. That's why I think the STANS Foundation holds this kind of symposium, which is very important for us. This slide shows the global aging. Actually, Japan is the only country where population of older people over 60 years old is more than 30%. This is the current situation. In 2030, many European countries join our group, along with South Korea and Taiwan. Actually, I think some people would know in the original figure, the color of Taiwan is light blue, but it changed because I think in 2013, the Taiwan were in our group, so that's why I changed. So I think Professor Chen Liangong showed this slide. This is the changes of aging rate in many countries. There is no line of Taiwan, but the line of Taiwan is completely overlapped with that with Korea. So Taiwan's getting old very rapidly. And this is our current situation. In 2016, 37.6% of the population is over 65 years old. And in 2030, 1 out of 3 of our population will be 65 years and over. More importantly, this population, older population over 75 years old, is increasing, but not younger old population. So the only age group in Japan which is increasing is 75 years old or over. And 2055, 2 out of 5 of our population will be 65 years old over. So can we survive? Japan, the question is, Japan can survive in this kind of society? That's a big for our country. According to our data, actually Japanese older people is getting younger, at least physically. We measured walking speed in 2000 and also 2010, and compared the walking speed in the same age group. And actually, recent older people can walk faster. And walking speed can predict the mortality. That's why we think Japanese older people are getting younger, at least in physically. So when I was a resident almost 32 years ago, disease management is the major issue for doctors, for making diagnosis and treatment. That's all. But now we need to deal with other issues related to aging of the population. And so now we need to deal with disability, and frailty. These are very important independent risk factors for older people. And this data show the 5 top causes of disability in Japan. As you know, stroke was the #1 cause of disability in Japanese people. But we are pretty good in the last 40 years in terms of the control of stroke incidence, probably due to the management of hypertension, and also we reduce the salt intake. That's why we can get dramatic decrease of stroke incidence. But instead, the role of dementia and senile weakness, joint disorder, and foral fracture is increasing. And these are related to frailty. So the major issue in this age society is dementia and frailty, on top, in addition to stroke. And of course, stroke management is important. We need to control blood pressure. We need to manage diabetes, dyslipidemia. But in current world, we need to also focus on dementia prevention and frailty prevention. And I think frailty is upstream of dementia. So if we can control or reduce the incidence of frailty in older people, we can reduce the incidence of dementia in the future. And actually, in UK and United States, age-adjusted incidence of dementia is start to decrease. So our future is not so dark, maybe bright in terms of dementia prevention. Although we are also developing new drug to prevent dementia, but I think by controlling or preventing frailty, we can decrease the incidence of dementia in the future in many countries. So disability is a major issue in Japanese society. So in the past, family members are major caregiver of disabled older people. But unfortunately, the caregiver's ability goes down in the last 20 or 30 years. I mean, the family power or community power are decreasing to take care of or look after disabled older people. That's why we started long-term care insurance system in 2000. And it's almost 18 years when since we started the long-term care insurance system. So this system, we basically learned this system from Germany and Denmark. And people over 40 years old need to pay premium and also government support by tax. So this system is supported by tax and also premium. And the user of the service need to pay 10%. So they have 10% co-payment. But it's a relatively good, cheap system. It's not free, but it's a relatively cheap system to provide sufficient care for disabled older people. And the goal of this long-term care insurance system is the following. The number one is to support the independence of older people. The second, it should be user-oriented. And this is the social insurance system. And this is the trajectory of medical care cost in Japan in the last 20 or 30 years. Currently, we need to spend 40 trillion Japanese yen for medical cost. And about 1/3 of the total cost goes to older people over 75 years old. So this is a huge amount of money. It's almost 10 trillion NT dollars. In terms of the cost for long-term care insurance, currently, this is a little bit old, but currently we need to spend 10 trillion yen per year, 10 trillion yen. So if we combine medical costs and long-term care costs, we need to spend 50 trillion yen per year. And for pension, in terms of pension, we need to spend the same amount, 50 trillion yen per year for pension. So altogether, we need to spend medical cost, long-term care cost, pension, 100 trillion yen, which accounts for almost 20% of GDP of Japan. It's a huge amount of money. So the government wants to reduce or cut this money for in the future. Otherwise, we will experience bankruptcy. So I'd like to talk about frailty prevention and dementia prevention, and also I'd like to just briefly mention about the role of our center. So what is frailty? Frailty is already addressed in the previous speakers, and frailty is a condition, age-related condition, by reduced physiological reserve, and also vulnerability to acute stresses like infection, incidents, surgery, and so forth. So it's a vulnerable condition. And the condition is between robustness and disability. And aging is the most important factor that affects the development of frailty. But at the same time, comorbidities such as lifestyle-related disease, like diabetes, obesity, vascular disease, cancer, polypharmacy, this means taking many medications, visual and hearing disturbances, sarcopenia, this means a low muscle mass and poor physical function, oral dysfunction, sedentary lifestyle, malnutrition, cognitive impairment, depression, and social isolation can affect this process. So multidisciplinary intervention is important. So in terms of social isolation, we have no power to improve social isolation. That's why the role of government and interest is very big. And frailty consists of 3 domains: physical domain, cognitive domain, and social domain. And there's a negative spiral among the 3 factors. So if, for example, if there is an impairment of physical domain, the impairment of physical ability can affect social domain and also cognitive domain. So we need to stop the negative spiral to prevent frailty and disability. Frailty is related to several healthcare adverse health outcomes such as disability, death, cardiovascular disease, falls and fracture, polypharmacy, emergency room visit, nursing home placement, dementia, and complication after surgery. And we started the huge human experiment in 2006 by introducing the screening system about frailty. So the original idea is screen all the older people with this Japanese frailty checklist and pick up high-risk people and bring them to the rehabilitation program. That's the original idea. But this idea is pretty good. But it's too early for Japanese society because only few healthcare professionals are aware of the importance of frailty prevention, and also all the citizens are not aware of the importance of frailty and disability. So this project failed, actually. But I think this is a good system. We can restart this kind of screening system in the future. But we just started too early. So this frailty checklist consists of 25 questions, like a comprehensive geriatric assessment score. And this is a yes or no question, so older people can answer yes or no. And only 25. It takes about 10 to 15 minutes to complete the questioning. And this question consists of 7 domains: activity of daily living, motor ability, nutrition, oral function, isolation, memory, and mood. So it's very comprehensive. And they can answer yes or no. So basically all the people can answer the question and mail back to the local government. And local government check their scores, and they pick up all the person with higher score and invite them to a rehabilitation program. But only couple percent, 2 or 3% of the older people with high risk can join the program. So that's why I said failed. Most of the older people with frailty did not attend the program. That's why they just didn't receive any kind of intervention, although they need some kind of intervention to prevent disability. But many researchers use this checklist to predict disability in Japanese older people. And usually we use new long-term care insurance service requirement certification as an outcome, which is almost equal to disability. And our hypothesis was older people with higher scores of Kihon checklist or frailty score have a higher risk for new long-term care insurance service requirement certification. That's our hypothesis. And that hypothesis was correct. We divided the cohort into 3 groups based on the Kihon checklist score. This group was, had the score from 0 to 3, 4 to 7, and 8 or over. And this group supposed to be frail. So this group showed higher instance of disability. And also this group had a higher instance of mortality compared to the other groups. And we have tried several intervention programs. This is one of them. I'd like to skip all the details, but basically we invited frail older people to exercise intervention program, and we provided exercise, 90 minutes exercise per day, 3 times a week. We continued the kind of intervention for 6 months, and we look at the outcome after 2 years. So 6-month intervention and follow-up for 2 years. And the outcome is shown like this. So we measured Kihon checklist score. Higher score means more frail. So they started from 7.5 in the intervention group. After 2 years, 1 year, the score was improved. But in the control group, the score was deteriorated, increased, which means in the natural course, frailty score increasing, but intervention stopped the increase of frailty scores. So this intervention was quite effective to reduce frailty in this cohort. And the outcome was long-term care insurance service requirement. We can reduce the instance by more than 50%. So disability rate was down more than 50%. And we also calculate the cost. And we can save almost 40 million Japanese yen in 2 years. So for the small local community, it's very beneficial to provide this kind of services to frail older people. And we actually divided the cohort into 3 groups: robust, pre-frail, frail group. And pre-frail means intermediate state between robustness and frailty. So in each group, for example, if you look at the walking speed, after the intervention, walking speed was improved. So this kind of program was effective in frail and also robust older people. We also provide different kind of program. The previous intervention was high-risk approach. We just invite high-risk people. We try to invite not frail older people. Of course, we include frail people, but also included less frail or non-frail people. This is the self-management exercise group intervention. And there's no healthcare professionals. Just this person, this lady is the volunteer who teach how to do exercise in the community. And there are almost 10 people in each group. And almost 10% of the older people join this kind of program in Maizuru City, which is located in Kyoto, Japan. And again, if we compare control and self-management group, there is a significant improvement in frailty in the intervention group, but not in the control group. As you can see, the frailty score is much less than the previous intervention. The previous intervention, the score was 7.5, And in this intervention, the score is 5.3. So this group was less frail. But still, we saw a significant effect by this kind of intervention. And this is in this figure, the outcome was disability. As you can see, this is the control group. And, this is the control group, and this is the intervention group. There was a significant effect by the intervention. So this kind of continuous self-management exercise can keep healthy condition of other people. We also divided the cohort into 3 groups, but in this case, we only saw the effect in frail older people. But I think we need to modify the study design. I cannot explain in detail about the reason, but basically, this group had the biggest benefit by this kind of self-management exercise. The next study is intervention by nutrition and exercise. And in this study, we communicate with the resident older people living in the community. So one of our research members in Tokyo communicate with the people in this area. This is a very rural area, and the major industry is fishing. And we basically ask all the people to check their daily activity. We gave them the step count pedometer and asked them to check the daily step count. And also we asked them to check the diet, what kind of diet they eat. And they need to send the report every month to one of our researchers. What we did was just calculate the average daily step count and send back the information to each older person and ask them to increase the step count by 10% in next month. So if they walk 5,000 steps per day on average, we ask them to walk at least 5,500 steps per day in next month. That's our way of communication between older people living in the community. And we divided the cohort into 3 groups. One is control groups. We didn't provide any services. The second group is just ask them to walk additional 10%. And the third group, in addition to walking recommendation, we provide protein supplement. When we compare the 3 groups, the first slide shows intervention group. In the intervention group, there's a significant increase of step count in 6 months. This is 6 months data. If you compare before and after the intervention, there was a significant increase of daily step count, almost 40% increase by just communication with our staff. And this is the data of skeletal muscle mass index. And compared to control, there was a significant increase of skeletal muscle mass by increasing the step count and also providing protein supplement. And this effect is more robust in people with frailty. So this kind of approach is very effective to improve frailty in older people. And this is the data showing the outcome, disability at the outcome. And again, frail older people had a significant benefit by this kind of intervention. Lastly, I'd like to show about the data of dementia prevention. This slide just simply showing that the incidence of dementia is increasing when we get old. So when you're 90 years old, almost 50% of the people, older people, get demented. And the prevalence or incidence of dementia expected to increase in many countries, including Asian countries. But as I mentioned, age-adjusted incidence of dementia start to decrease in the developed country like United States and United Kingdom. But according to current speculation, the number of demented older people is almost 5 million in Japan. So we have 30 million people in Japan, so 1 out of 6 older people is demented according to the latest survey. And this instance is pretty high considering other the incidence in other countries. Like in Taiwan, the incidence of dementia is only 5%. I think the difference can be explained by the difference of average age, because we have more older people over 75 years old. And dementia is a major problem of older people over 75 years old. That's why we have higher incidence of dementia. So in the future, you need to expect higher incidence of dementia in Taiwan as well. So you need to prepare that kind of situation in the future. So there we have adopted 3 steps for dementia prevention. The first step is general health checkup. And we, of course, use this kind of iPad to screen the cognitive function. We develop NCG FAT. This is like a very sophisticated measurement of cognitive function. And then we pick up high-risk older person and bring the person to our center and provide FDG PET, MRI, and NIRS. And actually, FDG PET is very expensive, so I'm not recommending this kind of test to other countries, but we have some grants, so we provide this kind of very expensive test for high-risk older persons. And then provide intervention. Shimada's group developed Cognicize. Cognicize means cognitive exercise. And this is very effective to improve cognitive function in MCI patients, people with MCI. This is a picture taken in the class. And Cognicize is kind of a dual task exercise. People need to do exercise along with calculating or saying something about the name of vegetable. So dual task approach. And they also check the incidence of MCI and frailty in the community. And the incidence of frailty is increasing when they get old. And almost 30% of the older people over 80 years old are frail. But in terms of the incidence of MCI, almost the same in each age group. The incidence of MCI is almost 20% from 65 to 80 years old. And so the incidence of frailty plus MCI is also age dependent. But the incidence is pretty low compared to the incidence of frailty. And this is the exercise intervention for frailty prevention. And this picture is exercise with learning task and aerobics exercise and muscle strength exercise. So they're providing different kind of exercise to prevent dementia. So a simple exercise is not good enough. We need to provide a little bit complicated exercise program to prevent dementia. So cognitive stimulation during exercise improve, maintain cognitive performance in older adult with amnestic MCI. So large-scale, high-quality LCT are required to determine if exercise reduces dementia incidence in those with MCI. So we need to create dementia-friendly society because we have almost 5 million people with dementia. And we have implemented new Orange Plan in 2015 to deal with this kind of situation. So we need to create a dementia-friendly society. And this is the 7 pillars of this new Orange Plan. And the first one is to promote awareness and understanding of dementia. Number 2, providing timely and appropriate health care and long-term care. Number 3, strengthening strategy against young onset dementia. Number 4, supporting caregivers. Number 5, creating community friendly to the elderly. Number 6, promoting research and development and its outcome dissemination. And then number 7, varying the perspective of people with dementia and their family members. So lastly, I'd like to mention about the role of NCGG. Our center is located in Nagoya City, which is almost the center of Japan. And our major target is dementia and frailty. And we started from hospital and research institute. But the current president, Toba, developed several centers to deal with each project, like robotic center, education and training center, medical genome center, Center for Development Advanced Medicine for Dementia. This center is for developing new drug for dementia. And I'm belonging to Center for Gerontology and Social Science, and we are providing intervention for preventing frailty and dementia in our center. And we have started integrated approach for frailty, collaborating with local government. And I don't have enough time to explain all the detail, but we try to invite pre-frail and frail older person from the community, and we assess about the frailty and provide some intervention, and send the patient back to primary care physician. We need collaboration to prevent frailty, and the collaboration with primary care physician is very important. So this is the take-home message of my talk. Frailty and dementia prevention is the key for healthy aging, and frailty and dementia can be prevented by multi-component intervention in which the role of industry and the government is critical. And collaboration between Taiwan and Japan is important for healthy aging of both populations. Thank you very much for your kind attention. 谢谢。
谢谢阿赖。